Give a quick introduction to Melinda before she gets started here. First of all, Melinda is an assistant professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health, and she's an investigator at the Institute for International Programs at Hopkins. Her research and teaching focus on large-scale effectiveness evaluations of health programs in low and middle-income countries and on efforts to improve measurement in maternal, newborn health, child, and nutrition. She's also the principal investigator of the Improving Coverage Measurement Project. So with that, Melinda.
Thanks, Cindy and Ellen, and thank you to all of you for being here today. I am going to give a quick overview of the Improving Coverage Measurement Project and talk a little bit about the methods that we use to set the stage for the results presentations that you'll be hearing next. So to start with, just a reminder of what we're talking about when we talk about intervention coverage. This is the proportion of individuals in need of a service or intervention who actually receive it. As Ellen mentioned, population-based coverage data are used for many purposes, and household sample surveys are the primary source of coverage data in low and middle-income countries. And one characteristic of these surveys is that whether people receive an intervention and whether they need the intervention, those things are self-reported by survey respondents. And so there is the potential for misclassification and bias. And so the objective of this work has been sort of to quantify, to understand how things are reported by survey respondents and what kind of error, reporting error occurs. So as Ellen mentioned, this work started under the CHIRG that established a working group on improving coverage measurement in 2009, and those results were published in a PLOS Medicine collection. And the work was subsequently funded as separate grants by the foundation. The objectives of the Improving Coverage Measurement Project are to produce evidence on the validity of priority MNCH interventions and to design and test methods for linking data on MNCH care seeking from household surveys with facility data. And I'll talk a little bit more about that at the end of this presentation. We also had a third objective around developing guidelines for visualizing coverage data that we're not going to cover today. The way ICM works is that we have a core group of technical subject matter and survey experts from a number of different institutions, and you'll hear from many of them today. Their names are on the right side of this slide. And these core group members provide technical guidance and leadership to the project. They provide guidance to different sub-studies, and core group members can also take on specific sub-studies. All of the validation studies in this supplement use the same basic design that was modeled after validation studies of diagnostic tests. And there is a paper on this in the supplement if you want to read about these methods in more detail. But basically, we start off by trying to obtain a gold standard measure of whether an intervention was delivered. And if it's a therapeutic intervention, we also try and obtain a gold standard measure of whether there was a need for the intervention, so what the diagnosis of the child or the woman was. Usually we do this by observing intervention delivery and obtaining a gold standard diagnosis if needed. We then wait some period of time, ideally based on the recall period in the DHS and mix. And then we conduct a household interview where we ask the DHS and mix questions, but then we can also ask questions that are formulated differently, additional questions. We can try out memory aids to see if any of those improve reporting. And then we can compare what was reported to what was observed to obtain measures of sensitivity, specificity, and so forth. So in terms of the data that we obtain from these studies, we get data on individual level accuracy, but also population level accuracy. And I'm going to talk about these separately. So individual level accuracy is, I think, what we're used to seeing. These are measures of sensitivity, or the proportion of individuals who received an intervention who correctly report having received that intervention, and specificity, which is the proportion of individuals who didn't receive an intervention who correctly report not having received received the intervention. We summarize sensitivity and specificity as the area under the receiver operating curve, or AUC. That's measured on a scale from 0 to 1, where 1 indicates perfect accuracy, 0.5 is a random guess, and less than 0.5 means it's actually misleading. And this group has tried to establish criteria for saying, for some of these measures to determine whether an indicator sort of is of acceptable accuracy to be included in surveys. So the criterion that we're using for AUC is 0.7. If the AUC is less than 0.7, then we think the indicator needs improvement and maybe isn't ready to be incorporated into large-scale household surveys. Population level accuracy is something that I think is people may be less familiar with. The idea here is basically saying if we were to measure this indicator in a household survey in this setting, to what extent would the household survey over or underreport the true coverage of the indicator? So we express this as the inflation factor, which is the ratio of estimated survey-based prevalence, so measured prevalence to true prevalence. And unlike individual level accuracy, population level accuracy varies based on the underlying true population coverage. So as true coverage or true prevalence changes, sensitivity and specificity balance each other out in different ways, and so you will get different sort of levels of over or underestimation of survey estimates. So we express this as this inflation factor, but in the papers in the supplement, you will also see this graph that sort of does show the inflation factor at a single point of true population coverage, but then also shows how that changes with different levels of underlying true population coverage. Okay, so how do we think about these validation results? How should we be interpreting this data? One thing that we try and emphasize is that we want to consider the individual study characteristics and context. So even though all these studies use the same basic approach to validation, we want to consider the specific context in which they were conducted. How generalizable is that to the settings in which we're interested? Also, which gold standard was used? How much error is there in that gold standard? Anytime we're trying to get a measure of the truth, there is going to be some error around that. And we try and be honest about sort of how close are we getting to, in fact, sort of true population, measuring what people truly got. And if there is error, do we think that is going to affect our estimates? We also want to recognize that these data are one piece of the puzzle. So there are lots of ways of assessing indicator validity, assessing sort of the feasibility of including an indicator in a survey, the quality of the data that's generated by questions. And these things need to be considered as a whole when you are trying to determine whether to include an indicator in a survey or not. That said, we do think that these data are useful, and we want to think about how they can be used to inform decisions about what should be collected in household surveys. Okay. I want to say something now about sort of what do we do in situations where we have high priority indicators or interventions that aren't well measured in household surveys. So this comes up a fair amount. What if, we validate something that we care a lot about, like antibiotics for pneumonia, and we find that it doesn't perform well? We don't want to just throw up our hands and say, we can't measure it, but we also don't necessarily want to measure something if it is inaccurate or misleading. And so this is something that the group has been wrestling a lot with. One thing that we have noted is that while there are certain things that survey respondents can't report well on, measures of care seeking in general seem to be well reported. So whether a woman attends ANC, whether she delivers at a health facility, whether a sick child is taken for care, in general seems to be accurately reported. And then on the other hand, we have data from health facility assessments that provide us information about the quality of service provision at health facilities. The downside to those, of course, is that they're not population representative. And so what we've been looking at is whether we can sort of take the best of both worlds and combine population-based information on care seeking from household surveys with information on service quality to obtain quality-adjusted measures of coverage. So, for example, an estimate of the proportion of women delivering at a facility that is ready to provide, high-quality management of labor and delivery. This is conceptually attractive. It is, sort of technologically or methodologically a little bit challenging. And so we'll talk this morning. There's one presentation that will discuss some of the methodological development and studies that this group has done to try and push these methods forward. So I'm going to stop there and just give you an idea of what we're going to be talking about for the rest of the morning. So now we will have 5 presentations of key results from this supplement, and followed by a panel discussion with some of the presenters, as well as Fred Arnold from the DHS and Shane Kahn from the Mix. So thank you.